Hello, everybody. So, today we're going to be looking at joints and joint actions. And by the end of today's session, you'll be able to demonstrate about joints. You'll be able to understand the different joints that we have and the different joint actions that occur. So, we're predominantly going to be looking at joint actions that you didn't learn at level 2. So it's well worth going back to any of your level 2 qualifications where you did anatomy to revise and refresh yourself on the different joint actions that occur at different joints. Now, I've attached a YouTube video below for you to watch that just to help remind you if you're struggling a little bit. I'll upload this PowerPoint onto Canvas, so you will be able to click on the link if you go to the PowerPoint as well as watching this video. So the first new movement we're going to look at is the one that occurs in the foot, and it's inversion and eversion. And I put some pictures in to help you see what happens here. So inversion is where you're turning the soles of your foot inwards, and eversion is when you're taking the soles of the foot up and out as if you're trying to lift up the little toe. So that movement occurs at the subtalar joint at the foot. That's kind of like the midfoot rather than it being at the ankle joint. So that might be a new word for you as well. The subtalar joint where you get inversion and eversion of the foot. And here you can just see a skeleton image of the foot moving in and the foot moving out, inversion and eversion. And the second lot of joint actions we're going to look at is that of opposition. And this movement is where our thumb is able to reach across and touch the fingers of the hand, creating opposition to any of the different fingers. And this is a unique movement that we as humans have and allows us to be very precise with gripping action. So the movement to create that grip is opposition, and then the reverse is called reposition. Opposition and reposition. There we go. Not one we tend to talk about a great deal in personal training or in sports massage, but a useful one to know. Now this one will be a lot more familiar, that of rotation. And if you recall, rotation happens where you have a ball and socket joint. And those, I'm sure you will remember, are in the shoulder and in the hips. So I've put in a picture down below to show you an example of the leg turning inwards where you have medial rotation and the leg turning outwards where you have lateral rotation. But it can look like a bit of a trick here because the picture on the left where the foot is moving across the body, and it might look like it's going inwards. Actually, the hip is externally rotating on the left image, and on the right image, where the foot is going out to the side, away from the body, the hip, if you can imagine, is actually internally or medially rotating. So if you just remember to be extra careful at the hip to make sure what's actually occurring at the hip joint rather than what you're seeing lower down in the leg. And the same occurs at the shoulder. For example, if you're doing a dumb waiter movement where the arms are going out, that's going to be lateral rotation. And when they come in, that's going to be internal or medial rotation. So let's go back to having a look at the upper part of the body, our shoulder girdle. Now, at our shoulder girdle, the bones we need to know about are our scapula at the back, which has an acromion process coming up over the top of our shoulder, which you can just feel as a bony bit on the top of the shoulder. Your clavicle, which is the long, slender bone that runs horizontally across your upper chest here, which you can feel just below your neck. Your sternum, which is the bone in the middle of your chest, your breastbone often it's called. So between these three bones, we've got articulations, joints that allow a great deal of movement to occur at the shoulder joint. So let me go down and show you a picture first. So here we've got, on the left, we've got the image of our scapula, and at the top of the scapula you can see the spine of the scapula running across and sticking out to form almost like a roof over the top of the humerus, and that's the acromion process, the bit right up over the head of the humerus. And then you can see the the bone of the humerus, which is your upper arm bone, and then this long thin bone, which is your clavicle here. So I've got another image here that shows it a little bit more clearly. So at the right hand side of the picture, where you've got your clavicle articulating with your sternum, you have your sternoclavicular joint. And then traveling to the outside of the shoulder, you've got your acromioclavicular joint, where the end of the clavicle articulates with that acromion, the process that comes up over from the scapula. Then dropping down to just underneath the AC joint, you've got your glenohumeral joint. And this is where the head of the humerus articulates with the glenoid cavity, which is that shallow cavity on the scapula. And then dropping down again, we've got what's called our scapulothoracic. It's not really a joint that we tend to think of, but it's the movement, the gliding movement of the scapula that happens around your rib cage, around your thorax. That's your scapulothoracic joint. But the main ones to think about here are your sternoclavicular and your acromioclavicular. See if there's anything else we need to say about that. Nope, I think that's all good. So those are the bones, and those are the names of the joints there. So moving on to your upper arm, only one to remember here, we've already seen it, and that's the humerus. Pop back up. And if you can see how it articulates with the scapula in that sort of curved area that's called the glenoid cavity. Now, the shoulder joint, as you can tell, has a huge amount of movement. So the joint itself is actually very, very shallow itself. You can see in the picture how that joint it's not holding the humerus in place at all. So for that joint to be stable, it's dependent on the rotator cuff muscles and also the ligaments that support it. But stability comes primarily from the rotator cuff muscles. And if you remember those, you'll be doing well. That's your supraspinatus, your infraspinatus, your subscapularis, and your teres minor. Those are your rotator cuff muscles, and they form literally like a cuff around the shoulder joint. There we go. So you can see how easily, without that muscular support, the head of the humerus would just drop down. And the bone nearest to us is your clavicle. The one coming up over the top of the humerus is your acromion. And then you can see the scapula in the background. Okay, so moving down to your lower arm, where you've got your elbow and your forearm. Now in your forearm, I want you to always think about standing in the anatomical position where the palms of your hands are facing forwards. Now, when you're in this position, the bone on the outside that kind of radiates out, how I always think of it, is your radius, the outer bone on this side of your body, on the side of your arm, and on the inside of your arm, you've got your ulna. Now, your ulna is actually the one that helps to create your elbow. And if you feel the bony bit, the back of your elbow, that's the top of your ulna, called the olecranon process. The top of the radius is actually a ring shape. So at the proximal end of these bones, the ulna is much bigger and the radius is smaller. Shows you here. So here you've got your arm bone, your upper arm, the humerus, proximal, so it's closer to the midline, radio-ulnar, the joint between your radius and your ulna. Here we've got our shaft of our ulna. Here the outer one is our radius. And then here we've got our distal radio-ulnar joint, the further away distal radio-ulnar joint. So they're connected to each other by a pivot joint. Do you remember the other pivot joint that we thought about was in our neck, in the upper part of our neck, formed by the atlas and the axis? But there's also a synovial pivot between our radius and our ulna, both at the proximal and distal ends. And these are our radio-ulnar joints. Now, I'd said that at the top of our forearm, the ulna is much more prominent, but at the distal end, it's the radius that's much more prominent. I'm just wondering if you can see it there. The radius is bigger at the base than the ulna is. So there we go. We've got our radio-ulnar joints, proximal and distal. So just moving down to our wrist and our hand now, and we've actually got 27 small bones in our hands, 8 of which are cuboid bones. Then we've got our carpals, which are formed by our gliding synovial joints. You don't need to know the names of all of these, which allow that large range of flexibility that we've got in our hands. So these carpals, these cuboid sort of squarish shaped bones, are roughly in 2 rows. And the 2 of the biggest of the first row form this synovial joint with the radius. So they articulate, the 2 biggest articulate with the radius. And then the 5 in the second row articulate with the metacarpals that fan out to form the palm. If I just go back to that image there, you can see these bones down the bottom articulating in the wrist and hand. Sorry, let me go on to slideshow. Oh, sorry, let me just find where we were, just so you have a better image. Okay, so we've got this idea of the 4 fingers now, not thinking about the thumb, just the fingers, and they've got 3 bony segments which articulate via hinge joints. If you flex and extend your fingers, you can see how they work as a hinge. Now, the thumb is a bit different. It's only got the 2 segments rather than the 3. And the thumb and the first metacarpal form a joint called the saddle joint. You might remember that. And I remember saying when you're riding on a horse and you have your thumbs, you've got to have your thumbs uppermost when you're holding on to the reins. So that's how I remember how it's a saddle joint, because you're on the horse. So that's your thumb. You've got a synovial saddle joint. So that's our shoulder girdle and our upper limb. So we're now going to move rapidly down towards our pelvic girdle. Now, our pelvic girdle is hugely important because it helps with the transmission of weight from our upper body right down appropriately through our legs to the ground without causing damage. And we need to have a strong pelvic girdle to ensure that we've got correct alignment of the spine. You'll often hear us talking about this neutral spine position where we've got our 4 natural curves of the spine, and our pelvis is critical to allowing this to happen. So it has to be strong and stable, and it's got to be able to cope with these real high amounts of stress that we put down through it in sort of running and moving movements that we do. So you've got 2 bones on either side. You've got your ilium, your ischium, and you've also got your pubis. The 2 bones are composed of 3 separate bones, your ilium, your ischium, and your pubic bones. And these all fuse together. So it's not easy when you're looking at the image to see which bit is which. But you can see from this picture here, starting at the top on the right, between our sacrum and our pelvis, we've got our sacroiliac joint, that's the ilium. The bits that the bones you can feel at the top of your hips are your iliac crests. Shows you which area is called the ilium. The acetabulum is the area where our hip bone articulates with. And our ischium, do you remember the bits, our sit bones, those itchy bum, the bits that we can feel right under our backsides, that's our ischium. And the bit in the middle that connects the two sides are pubic symphysis. And we have a cartilaginous disc here in the middle of the two pubic bones that allows a small amount of movement to ensure that the stresses can be transmitted appropriately. So as I've just said, we have this up. We create a pelvic bowl by these three different bones that are fused together. And we'll look in a minute about the difference between the male and the female pelvis. And this pad of cartilage, which is between the two pubic bones, that's important in stability and actually changes in pregnancy. And also we talk about stability being more important around the pelvis than around the shoulder girdle. We need more mobility in the shoulder girdle, more stability in the pelvic girdle. And this is affected by the ligaments and the alignment of the sacroiliac joint. Hugely important. So as I mentioned before, there's a difference in pregnancy in the pubic symphysis. So normally it can only move just a few millimeters, but in pregnancy, the body releases a hormone called relaxin, and it does what it says on the tin. It relaxes the ligaments to allow up to 9 millimeters of movement to obviously let the baby come out. So the effects of relaxin can actually be a problem as well as a help, because if you imagine all your joints becoming and your ligaments becoming laxer, this can cause a lot of pain because of the excess movement. So sometimes women during pregnancy have to have additional support around their pelvic girdle to help counteract the effect of the relaxin. And often in a physio department, you will see women coming in with this what's called pubic symphysis disorder. And this is where the two pubic bones are no longer correctly aligned, causing pain. But you can also get the separation of the pubic bones called diastasis symphysis pubis, which is a big problem. And you'd need to, if there's extreme pain in that area and a client of yours is pregnant, send them straight to the doctor. More generic pain is just called pelvic girdle pain, PGP. So those are just things to keep in mind. You wouldn't be diagnosing them yourself, but you need to be aware of the effect of the hormones on the pubic symphysis. So it'll come as no surprise that the male and female pelvic girdles look differently. So the male is narrower, and the female is wider and has a greater width in the bowl shape. So let's have a look here. So the male, just flip back if you look at that. So it has a narrow, and it's almost a heart shape. Can you see there's almost that heart shape of the pelvic bowl? The pelvic angle is almost vertical, as is the position of the acetabulum. Sorry, going the wrong way there. So the alignment of the acetabulum, remember that's the area in which the femur fits in. That's much more vertical than it is in the female. And you've got this thing called the Q angle between your hip and knee joints, allowing for the efficient transfer of force between the hip and knee. And the Q angle in males is small. Okay. Now, looking over to the female pelvic girdle, it's deeper and wider for the obvious reason that potentially would have to fit a baby's head through that. And there's greater curvature there, and it's actually tilted anteriorly, the whole pelvis, as opposed to the male. And the acetabulum are at more of a posterior tilt than in the male, and you've got a larger Q angle between the hip and the knee. And this can result in sort of a higher incidence of injury in females in running sports, because the stresses aren't so efficiently transmitted down the lower leg. So just remember, larger Q angle in women than men, the position of the acetabulum and the actual pelvic angle is different, and you've got this really noticeable difference in shape, the narrow heart shape and the much wider, deeper bowl shape. So moving down, we've got our knee joint and our lower leg. So the thigh bone is obviously your femur, as I'm sure you know, and then in the lower leg, you've got your tibia and your fibula. So the tibia is the larger of the bones, and that's because it transmits most of the weight from the femur down to the foot. And the fibula, the feeble fib, we often think, because it looks much weaker and narrower because it's not really weight bearing. It just looks like a stick that's kind of stuck on the side of the leg. It's very important for attachment and various other things. It kind of braces, helps to stabilize the tibia. And as I say, it provides an important attachment point for muscles. So you can see here the much wider, thicker tibia, and the fibula being the thinner one on the outside of the leg. And then the area between is called the interosseous membrane. So obviously you can't see it on the skeleton there, but there's a membrane that connects the two, just as there is in the forearm between the radius and the ulna. Now at the top of the picture here, you can see the end of our femur. And if you can see there, these two sort of articular surfaces, curved articular surfaces, which roll over the top of the tibia, and these are called your condyles. That's where your femur sort of splays out at its distal end and creates a medial and lateral condyle. And these are the areas that articulate with the top of the tibia, called tibial plateaus, a flat bit at the top of the tibia, and the condyles of your femur articulate. It's really worth having a look at the actual skeleton when you're in college to see that working. So here we go, just what I've said. So tibia articulates with the femur, and it has these little dips and depressions to allow the femoral condyles to form the knee joint. And as I'm sure you know, the knee and the elbow are hinge joints. And at hinge joints, you get the flexion and extension in, of course, that sagittal plane, as opposed to the hips, where we get abduction, adduction in the frontal plane. Now, the knee, you've got in front of the knee, you've got in the synovial cavity bursa, which are like fluid filled bags, which help to prevent friction between the bones and ligaments, or the tendon, and between the skin and the patella. So you've got a variety of bursa within your knee, which you need to be aware of. If you see swelling in the knee, it could be that you've got a bursitis. So that helps to cushion the knee and prevent friction. And you've also got cartilage in your knee, which sits on the top of the tibia, which prevents this kind of bone on bone grinding you'd otherwise get. And this helps to make the joint more stable, and they're known as menisci, your medial and lateral menisci, or meniscus singular. And as I say, this prevents this sort of lateral movement of the bones on each other and stabilizes those femoral condyles into place. So here we go. So it shows you the femur and the tibia, and you can see the white areas down on the top of the tibia. Those will be your menisci, your articular surfaces, and then you can see all the different ligaments that help support the knee. Now, the ligaments that go either side of the knee are your collateral, and you have the same collateral ligaments at the elbow to stabilize for the flexion extension. And you also have cruciate. Now, cruciate is anything that crosses. So you've got your anterior cruciate and your posterior cruciate ligaments. They're the ones to remember for your knee. So these cross over, hence the cruciate element. They give stability. And the other bone to know about is your patella. And if you remember, a sesamoid bone is one that's kind of embedded within a tendon, and the patella is embedded within your tendon from your quadriceps muscles. And so it's, in a way, it's sort of free floating. It's not attached to another bone, but it crosses the front of the joint, protects the knee, and helps to give the correct angle for the muscles to work in. So your cruciate ligaments and your patella in front of the knee, that sesamoid bone. So the knee, as I've said, it needs to be strengthened by the ligaments because you've got this the movement of the patella. All the ligaments and the muscles have to be well balanced to ensure you get that smooth tracking over the knee joint during movement. And the patellar ligament, is an extension of the quadriceps muscle tendon. So when we look at muscles, you'll see how all the tendons from the different quadriceps muscles merge together to form the patellar ligament, which attaches into the tibia. So moving down to our ankle and our foot. Now, if you recall, we looked at the bony structure of the hand, and we had the carpal bones there. And here in the foot, we've got our tarsal bones, again, roughly cuboidish in shape. And again, you've got the gliding action that happens between these synovial joints, between these cuboid tarsal bones. There's 7 tarsals, but you've got 2 big ones, which are your calcaneus and your talus. And right at the beginning, I talked about the subtalar. So that's the joint between the talus and the calcaneus, is the one where you get the inversion and eversion movement. And these are the ones that really, because they're sort of create your heel, really, they carry the most of the body weight. So your talus articulates with your tibia and fibula, where you get the 2 bones of your ankle, your tibia and fibula. And the heel bone is where the talus sits on, and you get your subtalar joint there. Here we go. So you can see where your heel is, that's your calcaneus, and the bone underneath the distal end of your tibia and fibula is your talus. Calcaneus at the bottom, talus above it. And then you can see the other cuboid bones, and then merging into your metatarsals and your phalanges, just as you have in the hand. So between the talus and the tibia and fibula, that's your ankle joint, if you like. It's not really called that, but you've just got a hinge movement. But then, so that's just your plantar and dorsiflexion. So dorsiflexion's when you're pulling your foot up towards you, plantar flexion's when you're pointing your toe down away from you. Dorsiflexion, plantar flexion, and that happens in the sagittal plane. All the other movements in the foot, all those different gliding movements that you've got between the different talar bones, allow your foot to be flexible enough to walk on uneven surface. So it can adapt to remold your foot to whatever surface or uneven surface you're walking on by allowing that inversion where your foot's coming in, or eversion, to allow it to be more supple and adaptable to the floor surface. Coming right down towards the end of the foot now, we've got our metatarsals, which are just the same as our metacarpals, with the idea of them being long bony cylinders. And the first and the fifth, one either side, make contact with the ground, and they're strong, those ones. And the others in the middle, form an arch. We have our arches in our foot, longitudinal and transverse arch, and the intermediate metatarsals form an arch. But they are more susceptible. They're not as strong, so they're more susceptible to fracture. And then finally, your phalanges, like your fingers, 3 different segments, apart from the big toe, which is more like your thumb, which has 2. But obviously they're smaller than in the fingers, so we have much smaller range of movement within those. So there we go. So that's the end of looking at our joints and our joint actions. Any questions? Come and see me.